अपने चैट में मैसेज डाल सकते हैं ना।
हाँ बिल्कुल, सबको अलाउ भी किया हुआ है। अगर उसको
अच्छा।
सबको बंद करना है तो वो भी कर सकते हैं, सब कर सकते हैं, मतलब दो दो पोस्ट।
हम लोग मैंने बंद कर दिया। हम लोग बंद कर दिया। वो यूट्यूब पर आता है। ये क्या, अब इसके बाद हम चैट पे गए।
यहाँ पे ऐसा क्यूए के बगल, ग्रीन के बगल, ग्रीन के बगल, जस्ट
ये भी सही
ये
वाला, ठीक। ये गए एवरीवन।
यहाँ पे भी डब्ल्यू पास।
ठीक है, एक सेकंड। अब हमारे यूट्यूब लाइव।
ये थोड़ा जूम लिंक
दूसरे कंप्यूटर में कनेक्ट हो गए, आ गए हैं। मैं आपको दोबारा लिंक भेजूं सर एक? मैं आपको अभी आपको भेजने सर, आप इसको बंद कर दीजिए एक बार, तो आपने लॉग आउट कर दिया। लिंक तो हमारा पैनलिस्ट में जाना,
हाँ
इनविटेशन।
पता नहीं। हाँ स्लोको तो ये खुला हुआ है।
सब वो लोग आपस में किसी को पूछ रहे हैं।
हाँ हाँ सर ये
ललित,
सर
एक बार
वीडियो नहीं आ रहा है सर। यू आर एबल टू लिसन सर नाउ? आर यू एबल टू लिसन?
सर, वॉइस आपकी क्लियर है। म्यूट कर देना।
हाँ हाँ सर, आपका
सर
वीडियो
आपकी
नहीं आ
वॉइस
रहा है।
बिल्कुल
हाँ हाँ तो मैं देख रहा हूँ कैमरा का।
प्राइवेसी सेटल होगा है।
सर ऊपर से अगर आपने देखिए प्राइवेसी चेक।
प्राइवेसी सेटल, एक मिनट से मैं इनको बोलता हूँ जरा, ये समझेंगे जरा, एक मिनट। प्राइवेसी सेटल इसमें कहाँ होता है? कैमरा क्यों नहीं खुल रहा है?
हेलो। हाँ जी सर। ओके, लॉग आउट करना पड़ेगा।
एक कर दो।
नहीं नहीं सर, वही मैं देख रही हूँ सर, जस्ट मोमेंट। इसका कैमरा। श्योर श्योर। श्योर सर।
बंद करो।
चलिए।
मैं कह रहा हमको अटेंडेंस जैसे ज्वाइन करा लूं तो हम उसको पहले बना देंगे। आपको इनवाइट किया था? शिट शिट। अगर मैं एक अटेंडी के लिंक भेज दूं अभी मेल कर तो उससे भी ज्वाइन करेंगे तो अपने आप ही आ जाएंगे अपने लिस्ट में।
पर क्या मेरा मेल करता है सर। मैं भेज देता हूँ, कॉपी कर लेता हूँ।
ईमेल आईडी पे
ये लीजिए कॉपी। कैसे भेजूँ
जी
कि
सर। ये ललित जो है ना याहू वाली जो आपकी ईमेल आईडी है। हाँ हाँ बिल्कुल। उसमें आप उसको डाल दीजिए ललित पैनलिस्ट की तरह। इसी ईमेल आईडी पे भेज दो। ललित क्या था उसमें से कॉपी करना है पैनलिस्ट की
ये
कॉपी।
ना
हाँ हाँ जूम लिंक लिख दो बस। जूम लिंक नीचे पेस्ट कर सेंड कर दो ये आ गया। अब उनको रजिस्टर करना होगा फिर एक लिंक जाएगा है। सर ऐसा कीजिए आप लकी नारायण साइट से एक मेल आई
रजिस्टर करना पड़ेगा। आ गए एज ए पैनलिस्ट है। पैनलिस्ट लिंक है ठीक
ये पैनलिस्ट
है।
है।
हाँ, कैमरा ऑन नहीं है, कैमरा ऑन नहीं है।
कैमरा ऑन नहीं हुआ ना।
मैं कह रहा हूँ स्लाइड ऑन कर।
स्लाइडर की है नहीं जैसे हमारे में नहीं है।
जैसे ही
तो कुछ पता नहीं किस तरह का हो क्या मालूम किस।
ऐसे कैमरा क्रॉस करा हो तो क्रॉस ऑन करवाइए। कैमरा क्रॉस करा होगा पास है।
नहीं नहीं उनको पता होगा। सर कैमरे में आपके क्रॉस तो नहीं बना हुआ ना। इसी से तो नहीं। साउंड भी तो नहीं आ रही। लाइट कैसे दिखाएंगे। लाइट हम अटेंडेंस से कनेक्ट बना सकते हैं।
सब कुछ कर सकते हैं बड़ा।
हाँ, हम लोग के तो सारे आ रहे हैं, आपका नहीं आ रहा बस। ऐसा कीजिए सर, मैं आपको एक आप ना आपको एक ईमेल गई होगी NAMS IT 05 से, अपना मेल आईडी चेक कीजिए, उसमें जूम लिंक लिखा होगा। पाँच तारीख लास्ट डेट है सर। उसमें जो है जी, अब उसमें आप अपना नाम और ईमेल आईडी डाल दीजिए, इसको लेकिन डिस्कनेक्ट करना होगा आप। एक बार लीव मीटिंग कर दीजिए, एक बार लीव मीटिंग कर दीजिए। हाँ, क्योंकि वो दो कनेक्शन नहीं हुए। हाँ, अब मोबाइल से भी हो गए। डाल दिया सर आपने, और इसके बाद इसको ओके कर दीजिए। यूजर आईडी पासवर्ड, सॉरी, आपका जो नाम, फर्स्ट नेम लास्ट नेम, इन्वर्टेड आ गया। उसमें सर नीचे लिखा होगा यू हैव सेंड ए मेल। आपका फर्स्ट नेम लास्ट नेम आपने डाला होगा, रजिस्ट्रेशन के लिए एक पेज आया, ओपन हुआ होगा। एक मेल उसमें लिखा होगा ना कि यू हैव सेंड ए मेल करके लिखा होगा। बैठे तो हैं। हाँ हाँ बिल्कुल। अब आप अपनी मेल आईडी चेक कीजिए, उसमें कंफर्मेशन मेल आई होगी, उसमें ज्वाइन वेबिनार करना है आपको। हाँ, आप कीजिए, आप ज्वाइन इसमें। ये आपका करेक्ट हुआ नहीं।
कंटिन्यू विद कंप्यूटर और
ये आपको बात
लॉन्च लॉन्च मीटिंग के लिए then select current computer audio, continue with computer audio, या join with computer audio।
सर, आप इसको वीडियो में ऑन करूँ आपका? वीडियो ऑन था। सर, एक बार रिक्वेस्ट, आप इसको ऑन कर दीजिए, अपना कैमरा फोन का। मैं आपको सामने दिख जाएगा मुझे। कर लूं?
सर मैं आपको दोबारा कॉल कर रहा हूँ।
इसी पे करूं? कोई बात करें।
प्लीज शो योर स्क्रीन।
सर, आप अपने स्क्रीन शो कर दीजिए, कैमरे को बैक कर दीजिए, तो हम स्क्रीन आपका देख लेंगे।
लॉन्च मीटिंग प्लीज, सेलेक्ट लॉन्च मीटिंग। So show the center of the screen, laptop screen. Uh, just join with video. So please show the center of the screen. laptop screen. Okay, you are joining now. Okay, so allow, please allow this. Okay, please allow this. Okay, okay. Sir, 1 second. Sir, no problem. नो प्रॉब्लम सर, आप लेफ्ट थोड़ा सा मुझे सेंटर पूरी स्क्रीन शो करिए प्लीज, जहाँ पे जूम का पेज, जहाँ पे सर इसको इसको फुल स्क्रीन करिए प्लीज, वहाँ पे राइट टॉप पे राइट।
तो बात ही हो रही है उससे उससे उन्हीं से बात हो रही है। ये क्या इसमें है, क्या कैमरा कहाँ रहा है? अच्छा सर, ऐसा कर सकते हैं आप सर, कि आप अपनी स्लाइड मुझे मेल कर दीजिए हमको, या सू सर स्लाइड मेल कर दिया आपकी ईमेल आईडी पे करिए। सर आपकी मेल आईडी पे करिए, आपकी आपकी मेल आईडी पे, डॉक्टर सू सर की मेल आईडी पे वो स्लाइड दे दिए तो मैं आपसे कर दूँ। ठीक है, तो आपकी साउंड आती रहेगी, हम स्लाइड यहाँ से आगे बढ़ाते रहेंगे। जी। हाँ हाँ हाँ। तो फिर ऐसे तो ये लोग कहते थे मीटिंग, और ये तो मीटिंग करते रहते हैं। हाँ, तो अभी ये पार्टिसिपेंट्स आ रहे हैं ना, एज ए पैनलिस्ट ज्वाइन हुए हैं। हाँ हाँ ठीक है, ठीक है, इनकी आवाज आ जाएगी, हम यहाँ से शेयर करेंगे। एनी डेस्क इनके पास होगा नहीं ना। अरे वो इतने डॉक्टर हैं, वो नहीं कर पाएंगे। एक काम करेंगे, मैं उनकी स्लाइड ले आएंगे, स्लाइड यहाँ पे आगे बढ़ाते जाएंगे, वो बोलते जाएंगे, उनको दिखती रहेगी। कितने लोग ज्वाइन हो गए? नहीं, वो उनकी बेटी है शायद भाई, तो अब अरे उन लोग अलग अलग है ना, टोटल मिला के 9 है ना।
फिर यहाँ पे आप देख सकते हो 6 पैनलिस्ट, 3 अटेंडीज, 4 अटेंडीज।
10 हो गए अब। जसवंत मिला है सर, जसवंत आ गए ना। जसवंत भी ज्वाइन नहीं किया सर, जसवंत ने भी ज्वाइन नहीं
नहीं अभी नहीं, अभी नहीं सर, अभी एज अटेंडी डॉक्टर आदिशेषा
किया। नहीं, पैनलिस्ट में आएंगे।
अभी उन्हीं
उमेश कपिल, उमेश कपिल, डॉक्टर ललित नहीं। आज उसको कहा था सर कि हाँ तुम ये सही फोन है। माइनस टू तो जाएगी। डेस्कटॉप नहीं तो हो गया। नहीं नहीं, मैंने अपने मोबाइल से करेंगे ना।
नाम से कनेक्टेड है मोबाइल से connected है।
वो अनस्टेबल रहता है, इसलिए हम जो है ना इससे करते कनेक्शन।
सर बोले तो सर का ऑडियो हम टेस्ट करते
ऑडियो तो आ ही रहा था ना।
हैं। अभी अभी फिर से बोल दो प्लीज कंफर्म कर लीजिए।
अच्छा।
ऑडियो ऑडियो भी आ नहीं रहा है।
हाँ सर। मैं भी बोल देता
सौराब नोएडा बीटल ऑर्किड।
हूँ। उनकी स्लाइड खुल गई। ओके, ओके। अच्छा, ललित सर से बात आती है।
ज्वाइन कर रहे हो, ज्वाइन कर लो, कोई दिक्कत आ रही है? ये बात बिल्कुल दिक्कत आ रही है।
हाँ, वो तो पूछेगा सर, रजिस्ट्रेशन आपके पास एक मेल आई होगी। जैसे आपने रजिस्टर्ड किया, हाँ जी सर। जी, जैसे आप रजिस्टर्ड करेंगे ना सर, आपके पास एक मेल पे मेल कंफर्मेशन मेल गई होगी। बस उसमें ज्वाइन वेबिनार कर दीजिए, है ना। हाँ, बस उसी पे ज्वाइन वेबिनार। हाँ, ठीक है। हाँ श्योर। आपका कनेक्ट हो जाएगा। हो गया ना। बिल्कुल बिल्कुल ठीक। आप बोलिए बोलिए, श्योर। जसवंत अटेंडीज, उनको पैनलिस्ट कर दो। आपने किस नाम से किया? जसवंत झांगरा ना सर। ये रहा, जसवंत झांगरा।
तो अभी मैं जैसे ही पेन लिस्ट पे प्रमोट करूंगा एक बार
हाँ, आप
वही
करो
ज्वाइन
आप। हाँ, यस कीजिए। हाँ, रीज्वाइनिंग, हाँ ठीक है। हाँ, आपकी आ गई।
वॉइस ऑडिबल है?
वॉइस ऑडिबल है। आपका कैमरा?
जी जी। सेकंड।
हाँ, आ गया, कैमरा आ गया। ठीक है।
थैंक
हाँ, ललित सर से क्या सर, अभी ललित सर से था, सबके आ रहे हैं, उन्हीं के नहीं। सर एक बार जरा सा आप बोलिए, क्योंकि आपकी यहाँ पे साउंड नहीं आ रही है। आप माइक पता करके बोलिए। अच्छा अच्छा, ठीक है। श्योर 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 श्योर। दूसरे लैपटॉप से चल रहे हैं। वो सर अभी दूसरे लैपटॉप से कर रहे हैं बात। रवि 23 इसमें आ गया आ गया। ठीक है। 3 बजे वाला शुरू कर रहा हूँ सर। 3 बजे वाला है ना। करा दूँ? एक्टिविटीज कर दूँ, ठीक है। रिकॉर्डिंग हाँ स्टार्ट कर दो।
Greetings from National Academy of Medical
वॉल्यूम बढ़ा
Science, India. Focusing on NAMS
इसको
Vision
ऐसे करते हैं, हाँ,
2030,
आवाज है।
NAMS is pleased to share some of the important activities like NAMS National, International Fellowship and Membership, Member After Day and Beam NAMS, NAMS
नहीं नहीं
Task
देखो रहने दो, कोई
AIIMS NAMS Navigate Medico CME, CME activities, publication of annals, newsletter, networking with professionals, public orations, Young Scientist Fellowship, Scientist Exchange Program, scientific visit of Emeritus Professor and many more activities. All application forms for fellowship, membership, associate fellowship, and member after day NB have been made online and objective criteria from the year 2022. NAMS has also started a new online NAMS Navigate CME and Navigate Medico CME program to assist in the development of competencies among PG students and share multimedia learning resource materials as e-library. NAMS has also started 21 task forces to address medical issues of national importance. Under publication activities, NAMS has its own annal as Annal of the National Academy of Medical Sciences. In addition, NAMS also publishes its quarterly NAMS newsletter. For more details of NAMS activities, please visit our NAMS website www.nams-india.in or scan QR codes with the camera app.
NAMS. You. क्या था पहले क्या प्रॉब्लम थी?
Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and biomedical professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in medical and biomedical professionals. NAMS is pleased to announce the launching of a joint AIIMS NAMS Navigate CME program from 1st September 2023 for postgraduate students in all the AIIMS and other eminent institutes of national importance from Andhra Pradesh, Arunachal Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Haryana, Himachal Pradesh, Jammu and Kashmir, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, Meghalaya, Mizoram, Nagaland, Odisha, Punjab, Rajasthan, Sikkim, Tamil Nadu, Telangana, Tripura, Uttar Pradesh and Uttarakhand of the country. The program is being conducted online on the first Friday of every month from 3 p.m. to 5 p.m. The AIIMS NAMS CME focuses on the topics which are of common interest for the postgraduates across all specialties. The aim of the National Virtual Postgraduate Medical CME is to help them to be more proficient in their profession. Each session will cover 2 topics. Each topic will be of 1 hour duration, which includes 45 minutes for presentation by speaker, 15 minutes for questions and answers. Thank you for your kind support.
Hello and welcome everyone to the first session on the cancer. So welcome to the next session of joint AIIMS NAMS Navigate CME program. And to continue with the session, today we are covering a very important topic, that is changing scenario of common cancers, mainly focusing on immunotherapy in cancer. So in order to start the CME today, I would like to welcome Secretary, National Academy of Medical Sciences, Professor Umesh Kapil sir, for the welcome address, please. It's over to Miss Kapil sir, please.
Oh, thank you, Jaswant, and congratulations that you have joined as an assistant professor
Thank you,
in
sir.
AIIMS Devagar. So
Thank you, sir.
really, we are proud of you. Uh, my welcome to the speaker, Professor Lalit Kumar, who is a pioneer in the field of bone marrow transplantation in the country. He is known internationally and internationally for his contribution. We miss you, sir, in All India Institute of Medical Sciences. Uh, my special welcome to the participants who have joined this particular CME. And what we are trying to do during through these CMEs is to help and update the knowledge of the postgraduate students who are doing their MD or MS, also of the DM and MCA students of all the specializations. So we are taking the topics which are of common interest to each and everyone so that their knowledge can be improved, their skills can be improved. The aim of this particular Navigate program is to reach the most peripheral doctor who have an opportunity to get updated in the field of one particular subject. And we have always had the best of the best faculty members from different AIIMS who can deliver the lecture, who has delivered the lecture in recent past. Today we have a very important topic on, if you look at the science in the treatment of cancer, immunotherapy has become one of the milestones. Gone are the days of 50 years back. Now we are doing, most of the cancers are being treated with immunotherapeutic approaches. So we have Professor Lalit Kumar who would be delivering the lecture today. And I request, my humble request to all the participants is that please ask as many questions as possible so that you get updated, your doubts are clarified, and others can also be benefited. I'll stop here. Thank you. Over to you, Jaswant.
Thank you, sir. Thank you, sir. So now continue with the session. We would like to listen to the address from President, National Academy of Medical Sciences, Professor Shiv K. Sarin, sir. We would listen to his message for all the participants and delegates.
On behalf of the National Academy of Medical Sciences, it gives me immense pleasure to invite you to this National Medical Postgraduate Virtual CME program to navigate our postgraduates to become better clinicians, better physicians, surgeons, and investigators, and also to be able to get into higher courses with ease. National Academy of Medical Sciences is your own academy. It is an umbrella organization which involves experts from all fields of medicine and paramedical departments. Also, it includes researchers and eminent scientists from overseas. National Academy helps to find the best talents, to recognize them, and also to request them to teach students and colleagues across. This CME program is very special because the Friday afternoon, 3 o'clock, is with All India Institute of Medical Sciences. As you know fully well, there are about 16 AIIMS in India, and these institutions of higher learning have joined hands with National Academy of Medical Sciences. The faculty there or the experts visiting these institutes are going to give their best pieces of knowledge to students and faculty across. I feel The knowledge given through these AIIMS and NAMS CME is of immense use to all our students. The National Academy will continue to strive and improve the clinical and knowledge base of our youngsters. I am very thankful to the director, AIIMS, Dr. Srinivas, who has consented to be part of this program, and also to all other directors of AIIMS who have given their time. I encourage you to invite students, motivate them to learn, and be with us every first Friday of the month from 3 to 5 p.m. With this, I welcome today's speaker. Thank you for your attention.
We thank you, Professor Siv K. Sarin, sir, for this address. And now, in continuation, I would like to invite Professor M. Srinivas for his address for this AIIMS NAMS Navigate CME program. Professor M. Srinivas is the director of AIIMS New Delhi. So now we'll listen to sir.
Namaskar. At the outset, I congratulate the team behind the NAMS AIIMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains a scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of department where our postgraduate students are working and will also bring in more flavor in their knowledge and at the same time ensure dissemination of uniform, high quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
Thank you for the message from Professor M. Srinivas, the director, AIIMS New Delhi. Now, we would like to welcome our eminent speaker for today's session, Professor Lalit Kumar. Sir is chairperson oncology and BIST at AIIMS Hospitals. Sir was former professor and head in the Department of Medical Oncology at AIIMS New Delhi. His areas of interests include blood stem cell, bone marrow transplantation, hematological malignancies, multiple myeloma, chronic myeloid leukemia, infections in the cancer, ovary, and cervix, and gynecological malignancies. He developed cost-effective treatment protocols for sustained bone marrow and stem cell transplantations. He has numerous honors and awards in his name. He has been honored with prestigious Padam Shri Award, Dr. B.C. Roy Award, the highest award by Indian government in the medical category. He has also been honored with ICMR Award, Ranbaxy Science Foundation Award. He is a fellow of Indian Academy of Sciences, National Academy of Medical Sciences of India, National Academy of Sciences. He is also a member of Institute of Women's Health of University College of London. He is also member of expert committee to examine the serious adverse events of deaths occurring during clinical trials. With these words, I would like to welcome Professor Lalit Kumar sir for his golden words to guide all of us. Welcome you, sir. Over to you, sir, please.
Okay. Good afternoon, dear friends. And it's my honor and privilege for this opportunity to share some of our thoughts with you today afternoon. So what I plan to do is over next 30 to 40 minutes is to give you some glimpse of what the incidence of cancer in India today, what is the changing pattern of various cancers, and how the treatment of this disease has advanced over the last 2 decades or so in terms of chemotherapy, targeted therapy, and immunotherapy. And how we can really look forward, how things can be moved forward. So if you see this here on your left side, in 1990, the non-communicable diseases accounted for 30% of all the diseases. But today, almost 60% of all the diseases are non-communicable diseases, which includes cardiovascular diseases, followed by cancer, then chronic respiratory diseases, and diabetes. So these are the main non-communicable diseases, which accounts for almost 60%. And if you see the common cancers among in India includes the 5 top common cancers in males include the lung, oral cavity, stomach, colorectal, and pharynx. While on the right side, you see in Delhi, it's lung, mouth, prostate, tongue, and larynx. While in other parts of country like Punjab, we have the Patiala cancer registry where we have the data. Esophagus is number 1 cancer, followed by lung cancer, prostate, tongue, and mouth cancer. And if you go to the down south, Tiruvananthapuram, where the lung is the most common, like other parts in the country, followed by prostate, mouth, tongue, and liver. Similarly, if you see the change in the pattern, like for women, the breast is the most common cancer throughout the country and also internationally. Though the incidence compared to 70 per 100,000 in the developed world, in India, the incidence for breast cancer is nearly close to 25 per 100,000. This is closely followed by cervix. Overall, if we see in the country, followed by colorectal cancer, ovary cancer, and lip and oral cavity cancer. But if you see in Delhi, we have the breast, cervix, followed by gallbladder cancer, ovary, and uterus. And again, we go to Punjab. From Patiala, we have the data again. Breast and cervix is followed by food pipe or esophagus cancer, followed by ovary and gallbladder. While in Tiruvananthapuram, again in Kerala, we have the breast, followed by thyroid cancer, ovary cancer, cervix, and then uterine cancer. These figures really represents the different etiological factors operating in different parts of the country. Like, for example, thyroid is the most common cancer, number 2 cancer in women in Tiruvananthapuram, while this is does not figure out internationally or in the rest of the country. Similarly, gallbladder cancer being number 3 in Delhi, again does not figure out in the other parts of the country in the top 5 cancers. The pattern of cancers which we have been seeing over the past 2 decades, there have been slow increase in the incidence of cancer. This is almost 2.7% in men, while in women, the increase has been nearly 3%. For breast cancer, the increase has been much more, nearly 4.7% per year. And some of the cancers where the trend has been on the rising incidence of cancer has been the colon cancer, rectum cancer, lung cancer, breast cancer, uterine, ovary, and prostate cancer. The only cancer where there has been decreasing trend is the cervical cancer. And as you can see in some of these pictures here, like for example, in colon, rectum, lung, and breast, there has been, this is data from the 5 cancer registries from the metros of the countries, which includes Bangalore, Chennai, Delhi, and Mumbai. All registries have shown slow and steady rise, except in the breast where the rise has been little much more steep compared to the others. The second important observation has been the lung cancer in women has been on the rise. Compared to males, this has been the women where it has been the much more increase in the incidence of lung cancer. Similarly, prostate, uterine cancer, again in the last 1 decade, there has been much more steeper rise for uterine cancer compared to the other cancers. While in cervix cancer, from all the registries, including the rural-based cancer registry, like Barsi, which is the rural-based cancer registry in Maharashtra, the incidence of cervix cancer has been on the downward trend. And we are hoping that now with the WHO plan that we should be able to eliminate cervical cancer by 2030. And yesterday, our finance minister announcing that some vaccine for cervical cancer, HPV vaccine, would be given free to the girls from 9 to 14 years of age. We hope that by next 20 years, that India will be a country where the cervical cancer will be very minimal, or will be almost to the, we will be repeating the story of polio vaccine, where the polio cases have been totally eliminated. So therefore, if you see the overall incidence, the different cancers, the breast has been much more increased, followed by the cervix and head and neck cancer. What is most important to realize is that almost 3 cancers, breast, cervix, and oral cavity, which accounts for nearly 1/3 of all cancers. And these are the 3 cancers which are amenable for prevention or early detection. Now, coming to the treatment part, we know that we have the surgery has been traditional treatment for treatment of cancer, either in terms of diagnosis or for early cancers as the definite treatment. Radiation, again, similar, and chemotherapy, hormonal therapy, and targeted therapy has been used for the treatment of the either adjuvant or neoadjuvant, where you give the initial chemotherapy, especially the locally advanced disease, to bring down the tumor size, reduce it, and followed by surgery or radiation. And recently, the immunotherapy also has been added in the treatment armamentarium for the last 1 decade, more so in the last 5 years. Let us see now. Now, let me first give tribute to person, Dr. Paul Ehrlich, who in 1908 was awarded Nobel Prize. He is considered to be the father of chemotherapy. He was the first one who gave the drug, that the drug treatment can be used for the treatment of cancer. Subsequently, the person, Sidney Farber, who is considered to be father of modern chemotherapy by the person who established the treatment for acute lymphoblastic leukemia through a series of studies, doing from 1 drug to 2 drugs and then 3 drugs, and came up that unless we do the systemic therapy treatment for acute lymphoblastic leukemia, the remissions which we achieve will not be long lasting. And as a result, so you can see on this slide, on the left side, if you see the curves, the earlier years, like 3 decades before 1960s and 70s, the survival used to be just about 20%. Today, the survival for acute lymphoblastic leukemia in children is almost to the tune of 80 to 90%. And the story has been reflected in India too, from 3 major centers like Mumbai, Tata Memorial Hospital, Mumbai, then All India Institute of Medical Sciences, New Delhi, and also Cancer Institute, ADR, where the results have been close to 70% long-term outcome, despite having many children coming with the very advanced disease, reflecting the successful outcome of this particular disease, which once used to be very, very fatal. Similarly, another example, I'm sure some of postgraduates may have seen these pictures, where the young age, you get the patients between 25 to 35 years coming with a Hodgkin's lymphoma. And in early stage, just giving 4 cycles of chemotherapy and with or without radiation, or in advanced disease, 6 to 8 cycles of chemotherapy with or without radiation to the bulky site generally is one of the standard of treatment. And as a result, in early stage, almost 90% of patients can achieve cure, long-term survival. Similarly, in advanced disease, stage 3 and stage 4, almost to the tune of more than 70% of patients do get cured of the Hodgkin's lymphoma. So these are some of the success story of lymphomas, Hodgkin diseases, which have been cured today with chemotherapy. Similarly, this is another, if you can see another success story, germ cell tumors of ovary. Both in germ cell tumor of ovary and testes, today chemotherapy is the mainstay of treatment. As a result, patients who are so-called early stage, when they are given adjuvant chemotherapy, because of their high risk for relapse, almost to the tune of 90% and above, can be expected to remain disease-free forever. And even in advanced disease, nearly to the tune of 80% of patients do get cured of this disease using a treatment protocol with the BEP, which is bleomycin, etoposide, and cisplatin. Now, just putting your attention to the modern targeted therapy. The story started somewhere in 1958 when Philadelphia chromosome was discovered by these Novel and Hungerford, and subsequently characterized by Janet Raleigh, as you can see in the left top corner, the pictures. And the people on the right side, they were the pioneers who came up with the targeted therapy, the first targeted therapy for any cancer, which came up, and this by the imatinib mesylate, or which is popular with the name of Gleevec. And this, the drug, which can replace this basically inhibits the tyrosine kinase enzyme phosphorylation. As a result, from ADP to ATP conversion, which is necessary for the cell to get activated and to divide. So this drug basically occupies this one of the ADP. As a result, the subsequent cell division stops there. And this drug has shown that today, as a single 1 tablet per day can result into the survival of more than 95% beyond 10 years or so. Today, the median survival for chronic myeloid leukemia is 25 years and above. So this is almost parallel to the normal survival in the community. So this is one disease where the first time the targeted therapy was shown that this could be successful in the treatment of this particular disease, where the bone marrow transplant only used to be the only treatment before year 2000. And today, so hardly any patient has to undergo bone marrow transplant for chronic myeloid leukemia. Now, another story is basically lung cancer. Many of us who were trained in the 80s and 90s have seen that the small lung cancer by diagnosed as non-small and small cell. These were the only two types, but in the last 2 decades, and especially in the last 15 years or so, we have seen that lung cancer itself at molecular level has multiple, these are the heterogeneous group of diseases which has multiple molecular pathologies. And adenocarcinoma, today we know that can have multiple mutations, which are, some of them are like driver mutations, like EGFR mutation, which has become one of the success story. And the data from both from India and abroad have shown that some of the EGFR mutation could be seen in almost 25 to 30% of these patients with adenocarcinoma of lung cancer. And this has resulted into the different publications from India, from different parts, ranging from 26 to 51%, showing the prevalence of mutation in these patients. And today, for any patients who has been diagnosed to have lung cancer adenocarcinoma, this is mandatory to do the EGFR mutation testing. And if they are positive, then they should receive the oral therapy, which will block this particular mutation. And as a result, you can see the survival of these patients has improved significantly. And today it's not uncommon to see patients of stage 3 and stage 4 lung cancer with adenocarcinoma histology surviving beyond 3 to 4 years, which used to be rarity just 15 or 20 years ago. Similarly, the other developments which have been seen is the carcinoma ovary. Now we know that BRCA1 and BRCA2 are the two genes which are generally seen in about nearly 15% of the cases, where there could be family history in good number of patients, or they could be not, or young patients sometime even without family history also may have these mutations. And again, from selected patients' profile, from 20% to 40% have been documented to have these mutations. And the importance of having this mutation lies in the fact that you can use the PARP1 inhibitors for these patients if they have the BRCA1 or BRCA2 mutation, because this is one of the enzyme which is necessary for the DNA repair, and the tumor cells are able to survive. And if you give them the PARP1 inhibitor like olaparib, you can see this. One of the recent study published 2018 have clearly shown that patients who receive maintenance therapy after the initial surgery and chemotherapy, if you give them maintenance therapy with the drug called olaparib, which is one of the key drugs for high-grade serous ovarian carcinoma with BRCA1 or BRCA2 positive mutation, there the long-term, the PFS, progression-free survival, is significantly superior for more than 5 years follow-up. So this has become one of the standard recommendation today for all patients of carcinoma ovary who are 45 years or younger, even for higher age or who have the family history, to do the testing for the BRCA1 and BRCA2 mutation. And so at least you can have one of the options for these patients in the terms of oral maintenance therapy. The other development in the field of oncology has been to measure the disease after the primary treatment has been completed, especially so we call it measurable residual disease, what earlier used to be called minimal residual disease. With availability of techniques like the flow cytometry and digital PCR And now we have the liquid cytology or cell-free DNA technology. So we can measure some of these parameters, especially the patients who have been so-called clear that imaging-wise, clinically, that there is no evidence of disease, but you can measure if they still have high risk of relapse in future or not. So by measuring MRD or measurable residual disease, one can predict the long-term outcome for these patients. So a lot of work has been done, and now particularly in childhood acute lymphoblastic leukemia, it has become one of the standard of care that all children after induction therapy has been done should undergo MRD testing. And if they still have MRD positive, the treatment become little more intensive. Those who are MRD negative, there they can be given the standard treatment. Similarly, multiple myeloma is another story where the MRD testing has become routinely available now, both with the help of flow cytometry and also with the help of ECR, and the clear data that those patients who are MRD negative, either post-transplant or with or without transplant, they have survived. Long-term outcome is significantly superior compared to those who have the MRD positive. So these are some of the advanced, and apart from ALL and multiple myeloma, acute myeloid leukemia also in certain cases where you have the marker gene which can be monitored subsequently. And now the story has been expanded to the chronic lymphocytic leukemia. Just about 4 weeks before, there was a major publication in the New England Journal of Medicine. I'm sure now we have some data on the liquid biopsy or so-called the cell-free DNA, measuring before the treatment and after the treatment, especially for the colon cancer, lung cancer. There is already some good papers have been published which show that this is a technique which is feasible and can be done to monitor these patients to measure the risk of recurrence. Now coming back to the final part, that it was year 2013 and 2014, where there have been two major publications by Science and Nature on the cancer immunotherapy. And the year was called the Year of Immunotherapy, where the first time it came clear that you can use the immunotherapy medicines or so-called for the treatment of many of these cancers. And this happened like after publication of number of papers. As you can see these images, on your left side, you have malignant melanoma showing after therapy, it's shrinking like anything. Similarly, another picture on the right side, we're showing on the left panel is showing the disseminated disease, the multiple advanced disease, deposits here, which have been significantly reduced or cleared by treatment with after 11 weeks after immunotherapy. Similarly, another example here, the melanoma on the right side and kidney cancer on your left side, where you have that the tumor has been shrunken significantly after the treatment with the immunotherapy 6 months later. And another case, head and neck cancer, you can see it here. After immunotherapy, there is significant response in this lady who was 96 years old and who have been treated earlier with the monoclonal antibodies. And she, because she was PD-L1 positive, and after 8 weeks, there has been significant response in her disease, has shrunken significantly. Another example, lung cancer, where you can see the before treatment and after 2 months of treatment and 4 months later, almost nearly completely resolution of the tumor in this particular case. You can see that there has been significantly reduced. These are some of the examples, and when these cases were published, people really took interest that, okay, that immunotherapy can be used for the treatment of cancer. And this is not the first time. In fact, people have been very curious, and they, over the last 100 years, in fact, the earliest publication has been 1918, where they collected 185 cases from the literature which shown that patients had spontaneous regression of tumors. Then subsequently, some of more publication, and finally we had one larger publication in 2005, and with 1,000 cases were documented in literature which had spontaneous tumor regression. And in this meta-analysis, they came out that possibly the frequency of a spontaneous regression of tumors happens 1 out of 60,000 to 100,000 of cancers. So that means the immune system is able to handle some of these tumors which can undergo. But why it happens in some cases, not in all, that is something always question which has been bothering to the scientist. And one of the major mechanisms among the various hallmarks of cancer, as you can see in this, the cancer cells are able to, or tumor cells are able to avoid immune destruction. That has been one of the major mechanisms. And as a result, the two particular things, the T cells, like, so we have the two mechanisms, either CTLA4 or you have the proteins like program cell death, PDL1, and program cell death ligand, and program cell death PD1 and PDL1, which are the one of the proteins which can really take care of the, so like if you block these proteins by inhibit them, then these T cells again can become functional and can able to take care of the tumor cells. So basically, so like what actually happens is that the cancer cells, they either may have some sort of genetic changes that make them less visible to the immune system, or may have proteins like PD1 or PDL1 or CTLA4 on their surface that turn off the immune cells. Or third mechanism could be they can change the microenvironment. Tumor cells change the normal cells around the tumor, that is the so-called microenvironment, so that immune system fails to really interfere with the cancer cells. So with these understanding, the people came up with some of these molecules, and some of the popular drugs, popular molecules which have been maximally used in the last 1 decade have been nivolumab and also the pembrolizumab, which are the PD1 and PDL1 monoclonal antibodies, and PD1 and PDL1 inhibitors, and have shown, like in you can see it here, that patients of RCC, renal cell cancer, who have the clear cell histology, they respond to these this immune checkpoint inhibitors, significantly improving the outcome for patient compared to only the targeted therapy. Similarly, the most amazing experience was published last year, where the patients who of the rectal cancer, 30 patients who were included in the study, stage 2 and stage 3, who were MMR deficient. And these patients of rectal cancer, when they were giving the monoclonal antibody, the immune checkpoint inhibitor, dostarlimab, and which was given 9 cycles to these 16 patients, in 14 patients, they were achievement of complete clinical response, which was confirmed by endoscopy, confirmed by the MRI, as well as the digital rectal examination. And as a result, this made such a it was news and published in the New England Journal of Medicine last year, that this is the one drug which can really take care of especially those MMR deficient, locally advanced rectal cancer, where the complete clinical response could be achieved with the use of this particular medication or drug. And these patients did not require any chemotherapy, radiation, or surgery. And so far, whatever the follow-up is available, for nearly almost 8 months or so, there was no evidence of recurrence in any of these 14 patients. So now the question comes, do every patient of malignancy benefits with these immune checkpoint inhibitors or immunotherapy? Now, there have been, in general, objective response rate of 15 to 30% in most tumors, but particularly the melanoma, Hodgkin's lymphoma, lung cancer, adenocarcinoma, and also squamous cell carcinoma, and squamous cell carcinoma of skin and genitourinary. And some of the cases of hepatocellular cell carcinoma, they do benefit almost in terms of 50 to 80% cases with these immune checkpoint inhibitors. So it is important to realize that all patients may not have the equal response. Therefore, the people have always looked up what could be the markers which can detect, which can help us to pick up which patient is really going to benefit. So there are three markers like PD-L1 expression. So either one can see the percentage of how much is expressed there, or total tumor mutational burden, and third is microsatellite instability, was deficient or proficient in terms particularly for the colorectal cancer. So these three markers are currently being investigated and being used for the tailoring the therapy for these cases. Since immunotherapy is prohibitively expensive, and the dosage which has been used over the years, there has been suggestion that patients that one can really use the off-label dose, which could be almost 1/3 than what is being recommended today. And this will bring down the cost significantly to the almost less than 1/3 than the current cost of the treatment. And one of the data which have been shown that if you use the drug, the 0.1 milligram per kilo is 2 weekly, and compared to this, then you can really, your cost comes down significantly low or cycle to cycle. And one of the very interesting paper was published recently, again from, this came from Tata Memorial Hospital, Bombay, and the investigators have very clearly shown that in patients who were newly diagnosed but very advanced disease, head and neck cancer, when they gave the oral therapy in one group and in another group, they gave the immunotherapy nivolumab, and which was given just in the very small dose, 20 milligram rather than 240 milligram, and every 3 weeks. Normal convention to give 200 milligram every 2 weeks. So, and they have been able to show that patients who received immune checkpoint inhibitors along with the oral therapy, they had the significant improvement in their PFS, progression-free, as well as overall survival. So this is something which really has intrigued people and currently being investigated so that more and more patients can benefit. However, before we really before we end this talk, let me also remind you that some patients may have toxicity. So one has to be very, very careful when you are using these drugs, and you have to select your patient carefully so that they do not develop the toxicity or have the minimal side effects with these drugs. Therefore, to summarize, today, in view of the population, some of the patients who have the high risk of developing some of these cancers, which I mentioned, and especially with the rising number of some of these cancers over the last 2 decades or so, it is very important to investigate the high-risk population, screen them for early diagnosis. And there have been always efforts to advocate to stop using tobacco and changing food habits. But the more important is to really do the research, how to change the behavior of the people towards use of tobacco and food habits, so they do not take the unhealthy food, or they take the more of healthy diet, which can, because like almost half of our cancers, either 1/3 are related to tobacco, another 1/3 are because of our food habits. So if we can really do something about these, I'm sure the number of these cancers will gradually come down. For patients with advanced disease, we need to really have, like, particularly with reference to immunotherapy, we need to have standard protocols in terms of the dose, in terms of schedule, whether 2 weekly or 3 weekly, whether we can use them upfront or in adjuvant setting after the primary treatment is done, or whether to use single agent or in combination. That is still one of the questions need to be really answered, and how we can really use the biomarkers and biomarkers driven treatment, which can really help so that only the people who benefit, they really are taken care of. And how long to give it, that is still one of the question. Generally, most of these clinical trials which have been published in the last 5 or 6 years generally have used the drugs for 2 years. But sometimes patients may have the disease, have responded, may have still minimal disease, whether to continue or not, that is still one of the questions which need to be answered. And I'm sure, like with our population, with number of cases which we have, we probably, if we can really get together, make a team effort, we will be able to really answer some of these questions. So, and the cost, of course, is one of the major thing. And I think the country like India, we really need to increase our health expenditure so that we can, some of this can benefit to our population. Thank you so much. So if there are any questions, I would be happy to take them.
Thank you, sir, for such a wonderful and enlightening session for all of us. There are 2 questions which have been posted in question and answer box.
Okay.
First question is, which is the most common carcinoma in India among males and females separately and overall?
Okay, so if you remember the first slide for the males and in women, we have shown that in general, lung cancer is the most common cancer in men, and in women, breast cancer is the most common cancer in women. So what was the second question?
The second question is a few queries regarding immunotherapy.
Okay.
Ability
Yes.
at community level, superior or whether superior to chemotherapy or for augmentation purpose only. And third is adverse effect profile as compared to traditional chemotherapy.
Okay. So immunotherapy is like similar to chemotherapy. There is a separate mechanism and separate method of treatment. So this is not a replacement for chemotherapy, or this is not something which. Except this rectal cancer where the immunotherapy was used. But in other cases, so far, people generally, this has been practiced in the patient with advanced disease and patient with stage 3 and 4. So after initial treatment has been done, so along with chemotherapy, either with chemotherapy or once chemotherapy has been done, then you can continue with the immunotherapy as a maintenance. So that is the one thing. And secondly, we still need to develop protocols, whether we can use the low dose immunotherapy, as I have shown you one of the study from TMH, Tata Memorial Hospital, where the low dose was as effective as generally the standard dose. The results have been quite, so that will really reduce the cost. The question was whether we can use in the community level. Yes, like if you have trained people who have been practicing it, they will be able to use it. Thirdly, like question was about the adverse reactions of immunotherapy. In general, most of the side effects are predictable. Now people have enough experience, and some of them side effects are generally, if you select your cases carefully, patients who are generally in good general physical condition, good performance status, they are able to tolerate it nicely. The very minimal side effects. But some of the autoimmune-like reactions or hypothyroidism, some of these side effects are there. With majority of them, they generally are manageable.
Thank you, sir. Next question is kindly comment on the hypothesis of abscopal effect killing primary removes mets. Practical experience, if any.
Okay. I think this has been described originally in the terms of radiation treatment, where that, like, for example, if you remove the spleen in earlier days or treat the spleen with the radiation, then you can see the tumor, the blood counts, for example, somebody having so that blood counts also comes down. So that's what's called the abscopal effect. So it was used in that sense.
Question is, what is present state of patient-specific immunotherapy using conditioned T cells?
Sorry, say it again, sir.
Present state of patient-specific immunotherapy using conditioned T cells.
Okay, actually, I did not cover that part. The CAR T cells is the chimeric antigen receptor T cells, and this has become this method of adaptive T cell immunotherapy, where the patients like acute lymphoblastic leukemia or non-Hodgkin's lymphoma, where you take out the T cells and then expand them, engineer them, expand them, and put them in the culture so they are expanded, and subsequently give them back to the patient, like autologous T cells, for example. So this is something like the conditioning basically is similar to so you treat them with chemotherapy and then give these cells back. So they will have an effect like a stem cell transplant. So the patients will recover. Now, the CAR T cell therapy has become sort of standard in last 4 or 5 years, and especially for the patients of acute lymphoblastic leukemia, where they have failed the initial induction, either first line therapy relapse, and after the relapse, first line relapse, then subsequently the CAR T cell results have been showing to be gratifying. And also some of the cases of the non-Hodgkin's lymphoma, diffuse large B cell, again, the patient who have relapsed and not responded to treatment, they are again the candidate for this particular therapy. Now, thirdly, the multiple myeloma, again, relapsed and refractory disease. This is another option. We call it BCMA. So B cell membrane antigen on the plasma cells, which also, so the CAR with using the BCMA are also being used for the treatment myeloma. So far, this has been used for the hematological malignancies. People are also trying whether this similar thing can be done in the solid tumor also, but that is still experimental. I should also inform you here that the last week there have been publication in New England Journal of Medicine where they found I think 16 cases of secondary cancers following treatment with the CAR T cells. So how our immune system handles these, that is something, though the number is very, very small. This is out of a few thousands of patients, that the 16 patients, they developed the secondary malignancies. But that is something, so it will be now interesting to really watch over next couple of years if we get some more cases of these secondary malignancies after this. My feeling is that patients who have been multiply treated, then undergo this kind of treatment, they have a higher chance compared to those who are being given this therapy, CAR T cell therapy, in the first relapse itself. The chances would be probably less of developing these kind of complications.
Thank you, sir. All the faculty members of AIIMS Devgar are actually, sir, watching this session live in the lecture theater. So one query is there, like one faculty asked your comment on ESMO clinical benefit scale.
Well,
clinical benefit scale.
I really have not much idea about ESMO clinical benefit scale.
Right.
I'll pass this.
Okay, sir. Sir, next question is chemo prevention measures. That has been asked only.
Okay, chemopreventive measures have been used in a number of cancers, like, for example, breast cancer. We have some of the, especially the women who are at high risk, or the women who have a strong family history, or women who are BRCA1, BRCA2 positive. There you really want, and they do not. So for such women, you have options either undergoing the surgery for removing the breast after or ovary, So the risk becomes minimized. But some of them who do not want to undergo this kind of procedure, then you can use some of the hormone therapy, raloxifene, tamoxifen, some of those things have been used, which can be used for such patients. So that is one of the people have been using for a couple of years. Then you have the pre-malignant conditions where you can use some of these preventive measures for the oral cancers particularly. So those are some of the drugs.
Thank you, sir. Thank you for the enriching session. So now I would like to invite Professor Ajay Kesud for the word of thanks. Over to Sood, sir, please. Sir, you are on mute.
So on behalf of the National Academy of Medical Sciences, it is indeed my great pleasure to thank the distinguished speaker for this evening, Dr. Lalit Kumar sir, for covering this topic in a very simple and comprehensive way. I'm sure the practical tips which you have given will be extremely useful to all the participants, especially to our students. Thank you so much for being with us this evening. And it was I really appreciate it was a very short notice, but you were able to make it. Thank you so much for being with us and your support to the National Academy of Medical Sciences. I will also like to thank all the directors, senior faculty members who have been a part of this program, encouraging the student to attend the program, as well as they have attended this program today and contributed in the discussion. So we look forward for your support. And once again, I make appeal to all the faculty members to give us suggestions on the topics and the topics which you would like to cover in future. So thank you so much for that. I will also like to thank the moderator for this evening, Dr. Jaswant, who has been helping us from the very beginning, and your support is of great help to us. Thank you so much, and we look forward for your help to the Academy. I would like to thank all the participants, especially the PG students, who have made this session very interactive by asking the question. So we thank you, and again, our appeal to you that encourage your fellow students to join this program. We have enrolled more than 1,000 PG students for this CME program. Your suggestion and also for the topics which you would like us to cover in future. For your information, we are having a parallel session on gastroenterology, and the last session on that series on gastroenterology is due on 16th of February, where we are going to cover a topic of acute pancreatitis. We are going to circulate the Zoom link and all the details very soon. And again, remember the next session in this series is on 1st of March, which is the first Friday of the next month. So with these words, I will also like to thank our IT team over here, especially Mr. Ravi and all the other people who have been helping us in getting this particular transmission on YouTube as well as on Zoom. So once again, I thank you all for being with us and making this session very, very interactive. Thank you very much. Over to you, Dr. Jasper.
Thank you, sir. So thank you for your kind words. And I think now, with your permission, we can mark the closure of this session.
Okay. Thank you so much. Thank you, Dr. Jasmine.
Thank you.